Good afternoon, everyone. My PhD topic is about the evaluation of new preoperative interventions in order to enhance recovery after major abdominal surgery. My name is Sebestyén and I work at Heim Children's Hospital, and I believe that there are some old paradigms in perioperative patient care that are old-fashioned now. We need a new approach, we need change, so my mission is to provide high quality of evidence to support this process. I have two ongoing projects at the moment. The first one is about the effects of preoperative carbohydrate loading on postoperative outcomes in patients undergoing elective major non-cardiac surgery. Currently, I'm writing my manuscript, and my target journal is the Annals of Surgery. So about the background. Traditionally, it is forbidden for patients to consume any kind of food or fluid prior surgery after midnight. This is called preoperative fasting, which is technically hunger or starvation that can last for 8, 10, or 12 hours. So it causes metabolic stress. And when this stress adds up with the surgical stress and the surgical trauma, these together can increase the rate of postoperative complications. Despite all these facts, preoperative fasting is still a worldwide routine. However, the most recent enhanced recovery after surgery guidelines strongly recommend the preoperative carbohydrate loading instead of fasting. So with this study, we would like to investigate the effects of this intervention, hoping that we can increase the level of evidence. Here's a clinical question. Does preoperative oral carbohydrate loading decrease the rate of postoperative complications compared to preoperative fasting? Our patient population includes adult patients undergoing elective major non-cardiac surgery. The intervention group will receive the preoperative carbohydrate loading. The comparison group receive placebo or they will fast. And our primary outcome is the length of hospital stay. We hypothesize that preoperative carbohydrate loading is superior to preoperative fasting. You can see the number of results in each databases we found during our search and our search key, of course. And after the selection, we found 55 eligible full texts. And now I would like to present you some of my results. When we compared the carbohydrate group with the fasting group, we found out that those patients who received the intervention had a shorter hospital stay. It's almost 2 days shorter, so it's clinically and statistically significant. However, the heterogeneity is very high. We haven't found the same results when we compared the carbohydrate group with placebo regarding this outcome. When we compared the fasting group with the carbohydrate group, we investigated the glucose levels, of course, on postoperative day 1 and 2. No significant results were found regarding this outcome. Regarding the insulin levels, no significant results as well. When we compared the carbohydrate group with the placebo group, we investigated the glucose levels and the insulin levels on postoperative day 1. No significant results were found. And the same happened with the CRP levels. Very high heterogeneity were observed in every outcome. So, in summary, this is a big number of eligible randomized control trials, but our population is very heterogeneous. There are different ways of administration of the preoperative carbohydrate loading, and there are different durations of fasting as well. So these are limiting factors, but in conclusion, we can state that preoperative carbohydrate loading may reduce the length of hospital stay, but it has some uncertain effects on postoperative glucose, insulin, and CRP levels. And the implication for research, we would like to recommend further studies to be performed with more homogeneous populations. My second project is about the multimodal individualized goal-directed fluid therapy, my GDFT for short, in patients undergoing pancreatic surgery. This is a protocol of a randomized trial. So Inadequate hemodynamic management during any kind of major surgery can result in either tissue hyperperfusion or fluid overload, and both are associated with worse postoperative outcomes, and pancreas is a very sensitive organ. It's very sensitive to fluid imbalance. There's an already well-working strategy called goal-directed fluid therapy, and our group would like to complement this approach with a multimodal contextualized concept. So we hope we can personalize this management even more. We would like to investigate the effects of the intraoperative MyGDFT compared to conventional fluid therapy. So here's a clinical question. Does MyGDFT reduce the postoperative complications compared to conventional fluid therapy in patients undergoing elective pancreatic surgery? So our patient populations, include adult patients undergoing elective pancreatic surgery. The intervention group will receive the MyGDFT approach. The comparison group will receive the conventional fluid therapy. About the outcomes, I would like to tell you a little more a few slides later. We hypothesized that the MyGDFT is superior to conventional fluid therapy. And the clinical implication is the lower overall complications and the faster hospital discharge. We would like to include adult patients from both sexes undergoing pancreatic surgery, ASA 1, 2, and 3 patients. We would like to exclude ASA 4 patients, pregnant or lactating women, and patients with inoperable pancreatic cancer. You can see the MyGDFT guided management compared with the conventional management. The intervention group, we would like to monitor more parameters in the intervention group with this device on the bottom of the slide called PulseFlex monitor. And here are the outcomes. The primary outcome is the overall complication rate according to Salzwedel. You can see what are included in this term called overall complication rate. It's infections, respiratory, cardiovascular complications, and so on. We have some secondary outcomes as well, such as length of hospital stay, intraoperative vasopressor requirement, lactate levels, and so on. So here are my 2 ongoing projects again. And I would like to thank you for your kind attention with a quote from Aristotle: by words, the mind is winged. Thank you.
So while conducting your research, could you notice any type of surgery which benefits more or less from this pre-surgical carbohydrate loading than others? For example, neurosurgery, pre-carbohydrate loading is better than in orthopedic surgery, vice versa. I think
yes,
you get it.
In abdominal surgeries, and especially in colorectal surgeries, carbohydrate loading is much more favored than fasting.
Well, if not, then Pani, thank you.